showed the decline was prior to your CMMI grant, and
Yes.
your slides show that it's continuing to improve, or
Yes,
at
I
least
think we are just showing the process measures right now. We don't have the outcomes, because I think the outcome analysis will be done by Alan and his team in the coming years. But no, I think that's great. You know, the numbers being shown as season of practice.
Okay. Okay. All right, terrific. Well, good afternoon. It is a delight to be here. I had the pleasure of meeting some of you not too long ago. And it's also a pleasure to be here in that, you know, while these guys who are talking, Bob and Hattie and others have acknowledged me and talked about sort of the work that a lot of us did sort of initially. That at the time we had some specific ideas. We had some very, you know, a clear framework of what we wanted to create. But the biggest part of it was that we really wanted to help plant a seed in the same way that we've talked about motivating patients to, you know, improving their PAM scores. We actually wanted to get the professional local communities engaged and inspired and active in the effort. And so one of the takeaways of the San Diego experience thus far is, you know, while there was some initial work of the University of Best Practices and all these guys, one of the secret ingredients is that eventually the local groups, the bear did help, but they found something that was worth putting in a hell of a lot of effort for and creating some of what we're going to talk about. All right. So I'm going to talk briefly about the Data for Quality project, and it is the Data for Quality project started about well, this actually started as the Data for Quality group. So you saw on the presentation from Brent and Susan where the University of Best Practice started in about 2011. One of the things that was clear that was needed was some sort of safe venue for creating, for sharing some data. And so the data group was one of the things that we established. In your handout, you have a brief summary that describes the history of, you know, the formation of the data group starting about 2011 and then proceeding up until about 2015. And it has been called the data group. It started out as the data group and eventually evolved into something we call Data for Quality Project. So this had, I mean, there's about, I'm not going to go into great detail about what's in there. You can look through that yourself. But there were a few key takeaways from this when we would look back and wanted to see sort of, you know, what can we learn from this? What's worked, what hasn't, and some of the things that we think distinguish at least this initial data group and Data for Quality project was that in addition to having some elements of a traditional quality collaborative where each of the individual organizations was seeking to improve their own performance on the diabetes and cardiovascular risk measures, and there was also a shared goal around making San Diego a heart attack and stroke-free zone, on following and tracking population health indices. And we're, you know, really trying to, as part of the whole effort, focus almost equally on looking at what is the impact, the collective impact of the groups, and where there are opportunities for either collective efforts or shared learning, where is that? And I think the other thing that was a takeaway, so you just saw a presentation from Parag. I had the pleasure of being part of that research effort as well, and advising and watching. Part of the fact that San Diego was able to get the CMMI project and do some of these other things and do stuff at that level really started out in some of the initial years of building some trust and working and starting to share some data. And we're now at the point where we're just starting to really get into it. But just very briefly, I want to highlight just two things from that early report. And one of the things was that while it took a little bit of effort to get some data, and we weren't necessarily able to get all the data we want or at the level of granularity we wanted, just the simple act of obtaining aggregate level data from all the groups and beginning to get it quarterly gave us a pretty sizable population. In San Diego, for example, for hypertension by 2014, across the 7 or 8 groups, and there's a little bit more than that actually, it was approaching nearly 200,000 people, which depending on what prevalence stats you're using in San Diego, was about 25% of the population. And so what that meant is we could start to talk about not only what it wasn't simply a matter of friendly competition and improving your performance 1% within your particular group, but collectively, if across that pooled population, whichever group did it or whichever ones did it in combination, at a population level, 1% improvement would be, in this case, in 2014, it was about 1760. We are, let's try that again. Okay. You can see about around the 2015-2016, we're about at 76% now. And then across the groups where we've set a informal goal of trying to improve at about 2% every year, which is actually pretty modest. For some groups, they've been able to make bigger gains. For others, they're already doing very well. So there's a little bit of a ceiling effect. But with this group, the participants that we've already got, even a 2% gain represents about 4,000 new patients who have their blood pressure controlled. Let's see here. Okay, so one of the things, as I said, it's got elements of the traditional quality collaborative, and some of the things that we can do now that we weren't able to do, one, without funding, but even without some of the kinds of software that's readily available now, is, in addition to meeting monthly and presenting to the group, so if, here's how you're all doing, we can actually give them online access to, in this case, this is built on Tableau, and each of the groups can now look at how they're doing. They can look at their own rates. These are interactive, so you can look across different measures, and they can see how they're doing compared to other groups. And that's, that in and of itself isn't that different, but now I'm starting to share this clicker, but hang on. Yay. But, we've also started to move towards beyond just sort of getting the aggregate across the population measures, and we've gradually been introducing some stratified measures. So for example, we knew there was evidence of gender differences in care outside of San Diego, and we've seen that in a lot of plans, particularly around CVD care. Here you can see even though this is within San Diego and this is across the groups, on the left you have the blood pressure control for diabetics, and here you're seeing virtually no difference. And typically what you'll see across a lot of measures is women will be doing slightly better because of utilization patterns, health behaviors. But for the LDL control among diabetics, there's about an 8 percentage point absolute difference. And that's a difference we've seen before, but it's been pretty persistent. And so this is something that even if you go to the newer measure, which is LDL control with, and you can say a moderate dose statin, we're still seeing some of this gender gaps persist. So one of the things that we're exploring this year is to begin to look at that in more depth. We can also start to look across different groups. So what you're seeing here is for those groups reporting this measure, on the top that you're seeing the quarterly rate. If you start from the left, that's the combined rate, and the tannish bar is actually men on top, which and that's it's about a 10% gap overall. And what you can see really quickly when you've got multiple groups reporting is you can compare you can see that the pattern's pretty persistent. Here you're seeing another thing that we're able to do now, which is we have on some pilot measures, we have zip code level data. And on the left, you're seeing the darker the area, that's where you have higher density of patients across different groups. On the right, you have the quality rates. And with hypertension control, it's pretty good. What you hope to see is sort of generally the bluer, the darker bluer is improved rates, or is better rates. The idea is for all of them to move it across to better performances, across all the different areas. But as you can also look at the variation within the different groups or between the different groups. And though some groups are doing consistently well across areas, some aren't. You can look for shared areas where there may be a potential hotspot, a candidate hotspot. So this is an area in Escondido with about 5,000 diabetics in it. And it was markedly below the the rates for the other areas. So that's a place we can investigate and see if it's a potential area, where it may make sense for all the groups to focus on, or some subset to focus on. As it turns out, it's a little bit trickier when you're working across, with a population and you have friendly competitors and groups that are performing at different levels. It's not necessarily as simple as just saying that let's find a place where the average rates are lower. You may want to find a place where, and the reason for that is you can have some groups that may have a higher concentration there and are performing at a lower level. If you're an individual group and a medical director, you're going to be ideally interested in focusing on areas where your group isn't doing as well as they are in other areas. And so part of what we're beginning to do is to look across the groups within areas to see whether, is this a problem for one or two groups, or is this a problem for all the groups? And here you're seeing just a percentage difference in points from each of the groups' individual means. What I'm not showing you there is we're now working with standard deviations to make it a little bit more standardized, but some of these red areas are 2 standard deviations below what is the mean for those particular groups. So there's something going on there, and you also want to find areas where several groups are working. We're looking at some of the social determinants that Bob referred to earlier, and this is just showing the correlation between diabetes control rates on the y-axis on the left with percentage poverty in each of the zip codes, and you can see there is a trend. Not a strong correlation, but it goes in the expected way. But it gets interesting when you start to look at the performance for different groups. So some groups may, because of the systems they've developed, the practices they've developed, may do better or may be able to mediate the effects of some of the social determinants, poverty, low education, better than other groups. And so here you're seeing some of the different patterns. So we're looking at that as well. This is showing, that line on the top is the expected rate of that relationship between LDL control and poverty we looked at. And remember we saw a hot spot in the big orange spot that was in the Escondido area of San Diego. What this is showing is it's a scatter plot where we've showed where there are outlier zip codes that are close to a standard, or 68 or 95% confidence intervals out. Most of these, and the ones in blues are the ones where you've got multiple groups serving in the area. One of the things that, while we want to, we're starting to look at social determinants, things like that, it is all the rage. I went to an equity conference in the East Coast. We don't know, what, I'm one of the people who's supposed to know a lot about this field. And, right now, a lot of regional collaboratives don't know. There's just not a lot of guidance. So we're just digging in the stuff across the different regional sites. Hopefully we'll shed some light on this. What this showed is basically that poverty didn't seem to be explaining the hot spot alone, because they were at all levels of poverty. Finally, I just wanted to make a nod to Brent and Susan and their wonderful work on the hospitalization. So here's your basic hospitalization trend, and it's dropping and so forth. And so ideally, there should at least be some correlation between their hospitalization rates and some of what we're doing. So here is our hypertension control rates, and it's going in the right direction. Diabetes, blood pressure control is even better. So exactly why that is, we don't know. We are starting to actually look at that, and we're going to be trying to collaborate and to understand this. One of the steps is to say, were the improvements in AMI hospitalization rates consistent across different parts of San Diego? Because we know at different points in time, in different places, there were different things going on in terms of initiatives at a community level or what some of the different systems were doing. If you look at these four grids, the one on the upper left corner is 2010. Move over to your right, that's 2012, then it goes 2013 and 2014. You can see that the rate, if you look in, say, upper around Oceanside, it's darker. In Escondido, it's darker. And then just sort of move through to the right, it lightens a little bit. In 2013, it lightens more, and so forth. So part of the challenge here is to start to tease apart, all right, well, let's say something was going on. Was there anything going on special that we were doing or others were doing that would explain the lightening in one area versus other areas? We're also, it's just to show, this is looking at, and this is the final slide of.
I just wanted to say we love Alan, and he could regale us with this all night.
Okay, last thing. So this is looking within the different areas. You can see the trend lines later.